Okay, guys, so it's 1:30. Please get settled. We can go ahead and get started. The sooner we start, the sooner we wrap up. How have things been with Dr. Culhane and hypertension? Okay, good. That's awesome. Okay, well, I have big shoes to fill then for the clinical part. Hopefully you guys like this part of hypertension just as much as you like the science part. I got some big updates. So I don't know, has anyone heard that the hypertension guidelines, they updated literally this week? Anyone hear of this?
Yes.
That's okay, good. Some of you are up to date. That's awesome. So prior to the update this week, they were from 2017. So 8 years old. They were mad old. So they updated literally Tuesday, and I had my slides ready to go from the 2017 version. So then I had to like fix it up and make sure that things were up to date. So you'll get what the most recent up-to-date version says as far as hypertension goes. The main things, well, I guess I'll get into it. I won't give you too much already, not to overwhelm you all. But before I get started, any questions about anything so far? Yes.
Yeah. So for the thiazide, like for the potassium sparing diuretics, like are they used? They're mostly used as a adjunct therapy, right? And they're very rarely used as a monotherapy.
Correct. For hypertension, yes.
For hypertension.
Yeah.
Okay.
And just to clarify, do you have a specific agent in mind when you ask that?
Just the one that's not spironolactone. The other one, I forgot the name. It's started with an A.
Acetazolamide.
Yeah.
Yeah. So we'll get into it, but that one, no, use more as adjunct. To clarify that further, we'll get into it, but potassium-sparing diuretics are used when, say, a thiazide diuretic lowers potassium levels. So then you use it in combination to make sure that the potassium is enough, as in the levels normalize. So like potassium-sparing ensures that the potassium levels are like adequate, whereas thiazide diuretics, they deplete the body of potassium. So that's why it's used in combination. But as far as potency goes for blood pressure control, they're not that good. They're not that strong. So that's why more is adjunct, yes. But we'll get into spironolactone too, because that's also an example of a potassium-sparing diuretic. That is potent. But more to come. That's a good question. Anything else that I can address right off the bat with hypertension? Dr. Culhane is a science expert, but I can try to like answer any science related questions. Obviously, like I learned it too once upon a time, but I see more of like the patient management side of hypertension, like what we do in terms of like the patient care aspect. But if you have science questions, like I'd be more than happy to clarify those. Dr. Culhane is out of the office today. So in that way, like if anything comes up, just let me know. Okay, so without further ado, so to give you a sense of how long this will go, technically, I have until Monday. So today, tomorrow, and Monday. I don't think I'm going to need Monday. So that's kind of nice. I hope you guys appreciate that. It's a slide deck of 77, 78 slides. Historically, I take about 2 days to get through it. So if I can give you a break on Monday, then hopefully you could just, I don't know, catch up. I'm sure you have other things going on. So that is the plan. So we will go over just definitions of hypertension, how to classify blood pressure, and then the goals for blood pressure that we have, what we do from a non-medication standpoint, so non-pharm, as well as medication standpoint, and then, just what we consider first line. We'll go over diuretics, RAS inhibitors, calcium channel blockers, beta blockers, monitoring, and then also like emergency type situations where like called a hypertensive crisis. And then also some special populations, aka like pregnant patients. So what our goals might be for them. From my understanding, you guys have reviewed diuretics, RAS inhibitors, calcium channel blockers, but you have not done beta blockers, correct? Okay, cool. That's fine. Beta blockers are first line anyway, and they'll come up later in the module, so we're not really gonna worry about that too much. You're not missing out. So these are just objectives. We'll define what hypertension means, causes and risk factors, complications, classify in terms of severity, what blood pressure goals are, all that stuff. And then patient-specific parameters, determine whether the patient should receive pharmacologic treatment in addition to non-pharm treatment, and then some non-pharm strategies. So just pretty much what the previous slide said. Some other things are, first-line therapy, and then based on patient-specific parameters, selecting the most appropriate course of treatment, common side effects, and then monitoring, and then differentiating between hypertensive urgency and emergency. Hypertensive urgency, per the latest guidelines, it's called severe hypertension, and I'll get to that later. And then, yeah, pretty much like what we'll do in that crisis situation, and then how we manage patients who are pregnant with hypertension. Okay, so intro. First and foremost, the definition of hypertension. This is basically, you just have elevated arterial blood pressure, which is measured on two separate occasions. So you have like two readings that you go off of to diagnose hypertension. This can be characterized by elevations in systolic, diastolic, or both. Systolic blood pressure refers to the pressure that's at the peak of contraction of the heart, whereas diastolic is the pressure that's during the filling of the cardiac chambers. And specifically, it's defined as a systolic blood pressure of 130 or higher, and, or not and, it's an or a diastolic blood pressure of 80 or higher. Okay, and again, you need two readings to be able to confirm the diagnosis. You can't just go off of one, but again, the or exists. So like say patient systolic is 140, and then their diastolic is 75. Technically, they still meet the definition criteria, but then they would need at least two readings to be consistent with the diagnosis. This is just an FYI slide, just to give you a sense of, how prevalent hypertension is. I'm sure at least one of you know of someone who has hypertension, or perhaps you have it. It is a manageable condition, very, very, our agents are fabulous. The first line therapies they work super well, and they do a great job at making sure patients' blood pressure stays controlled as long as they're taken correctly. So they work really, really well, but it is super prevalent. And then as far as gender differences in prevalence, they depend on age. So as you can see, with younger males, typically below the age of 65, men tend to have higher blood pressure. And then as, with the higher age, women tend to have higher blood pressure. So there's some variations in terms of that. And then somewhere in the middle, it's about the same, 50-50. Okay, so yes?
The second statement there, if normal BP at 55, lifestyle risk of developing hypertension is higher than 90%.
So if at the age of 55, someone has like a normal blood pressure, then their overall, hold on, let me dissect this a little bit. If they have a normal blood pressure at the age of 55, then the lifetime risk of developing a hypertension is higher than 90%. Just in terms of the prevalence, now this is given if someone is not regulating their lifestyle measures, and they're just, at standard, not really doing anything to manage, what would the non-pharmacologic aspects of managing their hypertension, if that makes sense. So this is just by default data that's looked at as far as a standard 55-year-old. as you get older, the chances of you developing hypertension becomes higher, unless you're doing something to manage that. Does that make sense?
It's not going with the. I was thinking that if at 55 you're not hypertensive, there is a chance that you will not even get hypertensive in life. If you say there's a higher chance, it's about 90% that you will get hypertensive.
If you have
What's the rationale?
Well, because age is a risk factor.
But based on the factors down there, with age, it seems as if it's also decreasing.
Could you clarify, like say that again?
Okay, age is a risk factor.
Correct.
At what age should we start getting worried about high blood pressure? Usually, if I can remember well, it's something from 35, 40.
55 and up. That's what the data suggests.
Okay, from 55.
Yes. So up until that point, if it's good and normal, all that stuff, great. Okay. But typically what the epidemiological data suggests is that usually as we start to get up in age, as we start to get older than the 55 age mark, and again, this will be varying, based on when we look at this, but usually that's usually the mark at which you start to see an increasing prevalence of developing hypertension without taking into account any intervention, non-farm or farm, without taking into account whether someone's restricting their salt intake, managing their diet, exercising, taking any medications, none of that. This is just taking into account the fact that age is considered a risk factor for acquiring hypertension. Does that make sense?
And I do have more or less doubt with what Kim raised. So is that line saying that a normal intensive person or a healthy person at age 55, it still has 90% chances of developing after 55?
That's what the data suggests.
Most people, even if they got to 55 healthy, most people are going to end up having.
That is, yes, that is the chance. And I know that's that might throw a lot of you off. I understand where you're coming from, so I see why you're picking this apart. But yeah, go ahead.
I'll just talk about that because taking that study into consideration, then 46% of American adults who have elevated pressure is a little bit lower, it should be probably higher. You have 90% chance at 55. Then
Now this number is constantly evolving, like the 46%. So it is probably higher, but it is going up. To answer that, yes. So the percentage is likely, it's probably more. But as far as someone who's always had normal blood pressure, now the chances with age going up, there is the likelihood, again, that it is going to be, they are predisposed to developing hypertension. Yes. So that is a possibility that exists. Okay. The lifetime risk. Now, when you pick apart the lifetime risk, that is the key thing there that you should pay attention to. What does this patient's lifestyle really look like? Are they doing things that are super healthy? Are they doing things that are erring on the side of, trying to maintain their blood pressure at a normal, within the normal range? Or are they not really caring for it? That's the part that I encourage you all to pay attention to or keep in mind. So risk is not the same thing as it is going to happen to you. Does that make sense? So that's the point to be made here. Does everyone register that? I appreciate you all picking this apart, actually. I was oh, it's just a fact, just to give you a sense, but and this isn't even the focus of where we're gonna go, but I appreciate you all picking it apart. Appreciate you all thinking this through. But this statement just essentially ought to highlight to you that as we age, our chances of developing hypertension increases as far as what the risk for that is. And so we have to take the measures non-pharmacologically. Hopefully that's adequate, but sometimes it means relying on medications to ensure that our blood pressure stays within control. And this will vary based on, patient-specific factors, which is actually, I think, the next slide. So a little bit of the risk factors as far as like what that, looks like. So when defining or like when looking at specific causes for primary hypertension, so we'll get into primary and secondary hypertension. Primary refers to high blood pressure that results from unknown pathophysiologic etiology. Like we don't know why. It can be cured, but it can be controlled. So that refers to like usually these risk factors lead to the development of primary hypertension. Modifiable cardiovascular disease risk factors are listed here for you. And as you look at them, hopefully you all can understand that why these are modifiable, considering a patient can work on these things. They can work on trying to quit smoking. They can work on managing their diabetes. They can work on managing their cholesterol. They can work on losing weight. They can work on exercising more, and they can work on modifying their diet to make it healthy. The difficult to change ones are the ones in the middle, and hopefully that's also intuitive. Chronic kidney disease by default is a progressive condition. You'll get more sense of this in renal, which will come up for you. But it's a little bit more difficult to regulate, which is why it's like not exactly modifiable. Low socioeconomic and educational status is like more of a social determinant of health. But, regardless, like it counts as a factor that could predispose patients to primary hypertension. So it's not always easy for us to make sure that a patient has perfect socioeconomic status. Obstructive sleep apnea, as well as psychosocial stress. Those are some other factors that we worry about or that would potentially be a cause for developing hypertension. And then we have unmodifiable risk factors, which are like kind of set, increased age, which is what we extensively discussed on the previous slide. Like as you get older, your chances of developing hypertension just go up. It is what it is. That's just the principle of aging. Family history, and then also the male gender. These are some things that, you can't really change them. It is what it is. So that, hopefully gives you a sense of things that we look for in patients and like how we approach them. Does that make sense? Any questions about that? Okay. So then there's secondary hypertension. This is high blood pressure where either a comorbid disease or a drug is responsible for elevating blood pressure. This is essentially like something we can clearly identify as a cause. The way that I think of it is like secondary means secondary to something. So in that way, like hypertension results secondary to, say, use of a medication, or having a certain condition that leads to that complication. So such disease states may be like chronic kidney disease, Cushing's syndrome, which is like this adrenal endocrine related disorder, which is typically due to steroid use, pregnancy, obstructive sleep apnea, thyroid disease, certain foods listed there for your reference, and then also medications. As a pharmacist, these are very, very important to review. So anytime we're evaluating a patient, I try to identify if a patient, say, like was consuming something or was on a medication that led to the elevation of their blood pressure. Secondary hypertension in terms of prevalence is higher. It's actually like, I think around 90% of patients have secondary hypertension. Primary is a little bit more rare. So like it's like around 10-ish%. Again, varying percentages in terms of prevalence, but this is the kind that I see the most in my clinical practice. This is not seen as frequently, but it's important to look at the risk factors and like immediately categorize which ones can I change and which ones can I not change, right? So those are the two different types. Any questions about the two categories? Okay. And then this is a nice little mnemonic for complications that can arise if a patient has uncontrolled blood pressure. So the MI refers to myocardial infarction. We'll get into that later in the module. coronary artery disease, we'll get into that later in the module, angina, aneurysm, atherosclerosis, all that will come up later. So these are just like complications that happen as a result of high blood pressure. The C is CHF and left ventricular hypertrophy, which is heart failure. And then CVA, TIA, so that's cerebrovascular accident. TIA is considered a mini stroke, transient ischemic attack. And then the kidney damage and then the eye damage. So those are some common things that can happen, and they're actually pretty scary. So that's why controlling blood pressure in patients is extremely crucial. Was there a question? Maybe I made that up. Okay. So as far as checking blood pressure, you all should remember this from Care Lab. P1 here, like it's like the first thing that you do, one of the first things that you do. There's the wonderful sphygmomanometer, which measures your blood pressure through auscultation on the patient's arm, and then the technique. So the NAPLEX, and again, NAPLEX seems far away, but it's actually not, does ask questions about the technique. So that's why like it is important to pay attention to, you know, how you're supposed to check. And that's why you do it in Care Lab, and that's why you see it again here. So you want to ensure that, like, it recommends you to check in both arms and use the higher reading. Now, I know in Care Lab, it's kind of like up to the patient's preference, so like up to whoever you're checking, they indicate to you, check it on my right or check it on my left. But again, this is coming straight from like the guidelines. So they say check in both arms, use a higher reading, wait 1 to 2 minutes in between the measurements, and then ensure the cuff is appropriate size. You all remember this. The patient's arm is supported and at heart level, and then they should have their feet resting on the floor and rest for at least 5 minutes. Does anyone remember, oh yeah, okay, it's here. The questions. Did you have any caffeine? Did you smoke? And did you exercise in the past 30 minutes? So those are the questions that you want to ask, and ensure that hopefully the patient hasn't done any of those, because they can adversely affect blood pressure. And so, yeah, and then you shouldn't be talking during the measurement. So pretty standard. All this is like review, because you did this before. Okay, and then the monitoring blood pressure at home. So this is done either by the patient or caregiver at home with your own cuff or the patient's own cuff. It's more cost effective and practical than using like the AmCare, the ambulatory blood pressure monitoring, but may not be as accurate. I mean, I think in today's day and age, like the blood pressure cuffs that you can purchase from your local pharmacy, those work pretty well. I don't think that they're, you know, to be doubted really, but it does help to, you know, again, like office visits, like with your doctor, like they may, you know, look a little bit different. I mean, they're usually within the same sort of range. So it's, you know, hopefully it's not too far off. But yeah, like the ones that you can purchase over the counter, they aren't as not reliable anymore. Like there used to be a time where it was like a little questionable, but I don't think that that's the case any longer. And then the readings usually are lower than an office measurement. So this is, I don't know how many of you have heard this before, the white coat phenomena. So it's just like you get super nervous going to the doctors, and, you know, it adversely increases and, you know, gives like a false higher reading of your blood pressure just because you're like all, you know, nervous during that appointment. So usually the readings at home are like more of an accurate depiction of what the blood pressure is. And then as far as like what patients look like and how we work them up. So the patients like that have high blood pressure, hypertension, they're usually asymptomatic, don't really have anything going on, which contributes to delayed diagnosis and medication noncompliance. Because if patients are not taking their medication as prescribed, they're like, I feel fine though. Like I don't really feel anything different. I'm good. And then when they check their blood pressure, it's like insanely high, you know? Yes, sometimes like you probably have heard the symptom of having like a headache or feeling lightheaded or feeling, you know, a little bit off in terms of that. But those things are like to the point where they may not always affect your activities of daily living. Like it's not limiting per se. So that's why patients don't really regard hypertension as like serious of a thing. Although it is very serious because as we discussed, like it could lead to all sorts of problems if not well controlled. So then the things that we do to work up patients are collect a comprehensive med history, including past medical history, medication history, social history, family history, look at their blood pressure, heart rate, and then their weight and BMI. And then we also collect labs to identify maybe like any sort of target organ damage or potential secondary causes. Target organ damage, we'll get to that with like more the hypertensive crises. That refers to like whether the hypertension has basically like worsened to the point where it's affecting other organs, which is really bad. Like we do not want that to happen. So we want to ensure that the patient isn't like, leading to kidney damage or like their eyes or, causing other issues beyond just the blood pressure being high. Yes.
How soon does that happen when it leads to organ damage?
There is no timeline. It could be literally at any point. And the problem is it's a silent killer. So you don't know how long like someone's been, maintaining a poor lifestyle. They haven't been looking after, their day-to-day and their well-being. And then they, typically we'll talk about the blood pressure reading. It's typically like at least 180 over 120. But we don't know exactly like how to anticipate that, which is scary. So yeah, it's not like linear whatsoever. I've seen patients who have had long-standing uncontrolled hypertension for years, but then I've also seen patients come in with target organ damage, and it's the first time that they're learning that they have hypertension, which is crazy. Yeah. So just because they don't, see a doctor regularly, they don't have a sense of what their blood pressure readings normally look like, or like whether they need to get that under control. So that does happen, and it's very scary. So yeah, and then regarding what we collect, so we look at electrolytes, we look at serum creatinine and BUN, which are markers of the kidney function, hemoglobin, A1C, to get a sense if they have diabetes and if that's controlled, and then lipid panel for cholesterol, and electrocardiogram to give a sense of if they have like any sort of arrhythmias, like abnormal rhythm disorders of the heart. So that's that. Any questions so far before we get into goals and classification? Oh, yes.
For just clarification, or just a curious question. If the patient has a family history of HTN, right?
Mm-hmm.
And for example, like their parents were diagnosed at a certain age, and the patient is like at a certain age, should we assume that they should be on medication, or?
It'll just be based on what their blood pressure looks like. So like if again, going back to the definition or diagnosis, 2 separate occasions of having a 130 or higher or an 80 or higher with systolic and diastolic. And then if that's the case, then they would be a candidate to receive treatment, like a medication for that. Yep. Well, the guidelines updated, JK, let me get back to that. Okay, it looks a little bit different now, actually. Okay, sorry. I'm like thinking 2017 still. The guidelines updated Tuesday, so bear with me. There's not anything changing in terms of the treatments. Like, thankfully, all the first-line agents are the same, but I'll get to what I mean. Okay, any other questions? That's a great point. I'm going to come back to that. Any other questions before I move on? Okay, classification and goals. So this is a nice little table that helps for you to determine like where a patient's at. Normal blood pressure is considered less than 120 over 80. Okay, elevated is somewhere from 120 to 129, and a diastolic of less than 80. Okay, so I would recommend paying attention to the and the or. So like, as you can see, normal and elevated have like, you need both as and. So like less than 120 over 80 is the case for normal. Elevated is a systolic of 120 to 129 and a diastolic of less than 80. Stage 1 and 2, that's where we get into the ors. So 130 to 139 or a diastolic of 80 to 89. That's considered stage 1. And then stage 2 is when we have a systolic of 140 or higher, or a diastolic of 90 or higher. Okay, and then crisis, as mentioned briefly before, that's if you have a systolic of 180 or more, or a diastolic of 120 or more. Okay, so all that's highlighted for you. And then we average 2 or more blood pressure readings taken on 2 separate occasions. So if we have, basically that indicates to us a persistent elevation of blood pressure. Like a one random read is not going to indicate to us that the patient has blood pressure. You know, there could be multiple factors that could lead to like an elevated reading out of nowhere, but you would need more than just that to confirm its diagnosis. And then if it's systolic and diastolic give different categories, then you use the higher of the 2, which just goes back to like the ORs. So you would still count the patient as being in stage 1 if, say, their systolic is like 135 and their diastolic was like 75, you know? So even if it's not exactly in that range, you would still be able to use their systolic reading to categorize them in stage 1. Does that make sense?
The patient on 125/80 will be elevated.
Yes. Well, technically, so that's less than 80. So you said 125/80?
Yes.
So technically, they fall in stage 1 because of their diastolic, because 80, it includes that 80 read. Make sense? And then where we have normal and elevated, that's like less than. So it does not include 80.
Does this have anything to do with race?
This is irrespective of that. So there are cases in which patients tend to run higher, but when it comes to categorizing patients, this is the standard. So like this is irrespective of your background, ethnicity, race, whatever. It does not take that into account. This is just the staging part. What you maybe think of is like just as far as how we approach them. And again, I'll get to that piece because the guidelines did something nice to account for, well, not race, but something else. But any questions about the categories? Okay. Awesome. So then the things that we try to do with controlling blood pressure, obviously lower the risk of death, reducing morbidity and mortality, lower the risk of death, and then also like risk of developing like any other condition or any other complication from any sort of cardiovascular event, and then also kidney disease. And then the patient-oriented evidence that matters mainly just refers to the fact that like reducing blood pressure will decrease stroke, myocardial infarction, and heart failure incidence. So when we get hypertension under control, it really helps to control the development of all the other complications, like the other cardiovascular issues that come up, which we will talk about as the module goes on. So hypertension is kind of like that first thing, like first cause for a lot of the things that come up. If we get it under control, then we can do a nice job at making sure the rest of the problems don't follow. Okay, so as far as the exact blood pressure goals, so with patients who are under 65, and then if they have comorbidities, I would say like this is actually applicable for most patients that I see. We try to aim for a blood pressure read of less than 130/80. That's kind of like the rule of thumb. This is just what we do. Less than 130/80 is what we try to aim for everyone. And then when we get into like the older patients, so when we have like those who are 65 and up, who are institutionalized, non-ambulatory, or not living in the community, like they're to the point where like they have a lower life expectancy essentially, then we can consider more of a relaxed goal. That's the idea, based on clinical judgment and then also patient and family goals. So things become a little bit less intense as patients' age goes up. With that being said, like it might be like as mentioned, so like less than 140 or 140 as a systolic read, or less than 150. I usually see less than 140, and we primarily focus on the systolic, just as far as like the outcomes that systolic has on just overall cardiovascular outcomes. So, but what I would keep in mind from your standpoint would be like, you're going to see most likely a blood pressure goal of less than 130/80 for almost all patients. Any questions about that? Yes.
I was talking the other day with Ernesto. My understanding is that there's no way to isolate systolic blood pressure control, but if you have a person that has only systolic blood pressure increase out of the range, is there a way to target that without decreasing the diastolic?
No, unfortunately. So it is a combination reading, as you said. Like it's not. There's no isolated measure where like you do something and it only targets systolic blood pressure versus diastolic. So no, it's not really linear that way. But again, systolic sometimes is used as a target because of it's like how it corresponds to cardiovascular outcomes. Like there's just better outcomes if you get that under control, or so that's thought to be the case. But there is nothing like it would be the same measures that you would have in general to get it in under the like below 130/80. Same thing that you would do. Yeah.
And how comfortable would you feel pushing the diastolic down so the systolic is allowed to be decreased as much as possible?
They are independent of each other because like they refer to different parts of just like systolic refers to more the contraction of the heart, and then the diastolic is more like the filling part of the chambers. So those two are not related. So sometimes like we do see lower diastolic reads, but it's never corresponding to one another, if that makes sense. There isn't really a way for us to like try and strategize how we're going to keep one normal and then try to lower the other. Like there isn't really a way of trying to do that, if that makes sense.
Yes. But what I was saying is more like since both of them go down, how far below 80 can you push the diastolic down so you actually are able to get the systolic, which is still out of range?
Yeah, well, so I can answer what the lowest limit of normal would be for a diastolic read. That's probably around like 60 millimeters mercury. If it goes below that, then that is considered like we're getting low. Just to give you a sense of what is considered like a hypotensive read, that would be like around. Now, this varies because it depends on the symptoms that the patient's having. If they're feeling lightheaded, dizzy, and like, just unable to concentrate and they're not with it, then we would go off of the symptoms. But like usually 90/60 is where we're concerned that like this is too low. 90/60 or lower, pretty much. But then there's patients who are symptomatic when they're like around 100/60 or 100/70. So the symptoms are more top priority to ensure that the patient doesn't like faint or, like they're not able to carry on with their activities of daily living. So yeah, so that it varies based on how the patient's doing. But if we're looking at just from an objective standpoint, just looking at the read itself, then 90/60 or lower is kind of where like we're like, okay, this is getting really extreme. So yeah, that's a good point though. But
so if we have a patient with 158, what would we do?
Are they having symptoms?
No symptoms, but it's coming with 100 and it's systolic and the diastolic like 55.
Yeah, so it depends on the symptoms, depends on what their general pattern or like trend is in terms of blood pressure. Because I'm sure some of you, does anyone know of like, someone who just runs low in their blood pressure? Either during lab, you probably saw that, or like you just saw, it's just normal for them. So there's that group of people too, where it's just like, they're like, oh yeah, I'm good. I'm like, in this range and I'm good. But when it's like, say like 80 some over 50 some, that's crazy low. Like that's where we're like, oh my God. So like I start to worry when I start to see a consistent trend of 90/60 or lower. Where you're saying I would have those follow-up questions. The symptoms, are you normally around this? Is it affecting your activities of daily living? Those sorts of things.
Not the diastolic for this patient, The systolic is always around 100 and above, but the diastolic is always pushing 60 and below.
Mm-hmm.
But the systolic is always 100 and above, 100, 105, 110. But diastolic, you're looking at 60, 58, 55, and that is consistent.
That's fine. If it's okay with the patient, if they're not having symptoms, they're not feeling lightheaded, they're not fainting. The other thing is that these numbers, obviously we have goals here and we have, like, as I pointed out, what a low blood pressure technically is and what patterns we look for. But the key thing with, like, from a clinical standpoint with hypertension is we're not always trying to treat a number. So it's not always just about, okay, well, we just need to, like, get them to this point. It's not always that. And I say that loosely because, like as I'm pointing out here, like, we want to have most patients under 130 over 80, but sometimes, like, if their trend has been just on the lower end, then technically we don't need to really worry if they're not feeling uncomfortable by it, and if that's just what's normal for them, you know. So it's not always about, like, okay, if their diastolic is consistently in the 50s, that number shouldn't bother us if it's not being concerning for the patient. If that makes sense.
Yeah. One more question.
Yeah.
The upper end of the spectrum. I know of a patient who is consistently on 170. No matter what you do with medications, he's on the 170, 180. Medication brought him down from 190 to 170
Okay.
on the systolic, and the diastolic is always around 140. And that's normal for this patient. Nobody classified.
Yeah, we'll get to the treatment. We're getting there. All right. So I'll get into that more.
He's currently undergoing treatment right now.
Okay.
So the blood pressure doesn't change. I'm telling you, he's still within the same range. How do we classify that kind of patient? Do we classify him as stage 2 because based on class?
Yeah, it is stage 2.
Okay, but that patient has been like this for more than 10 years.
I have a lot of questions then, like about medications, how many medications are there, what has been done as far as, like, resistance goes, but I'm not trying to get ahead of myself for everyone. We're going to get to the treatment part shortly. But at this time, again, let's stay with what we're covering so far, and we'll get to this treatment part step by step. But any questions as far as the goals go? So I'll come back to that when we talk about treatment. And I'll ask you questions about that particular case. But for now, anything that anyone wants to clarify with this? Cool. Okay, finally, treatment. Here we go. So we have a 2025 guideline update. So when to start medications for patients? All right, this is important. Listen up. So if there are no clinical cardiovascular disease conditions that the patient has, but they have diabetes, chronic kidney disease, or they have a 7.5% or higher 10-year cardiovascular disease risk, which I will address with this percentage where it comes from, then you would start the medications if the blood pressure is 130 over 80 or higher. This is like bullets. I'm going to give you all this in table format. Does it, like, well, I'll go over this first, and if this registers with some of you, great, but if not, it's okay, because the next slide is a table, and I think that might be easier to look at, but we'll just go over it with this slide first. If the patient does not have any cardiovascular disease and their risk is less than 7.5%, then you try lifestyle changes first, which is done for 3 to 6 months. So I think, Jesse, we were talking about this, like, I forget what we were talking about at that point, but I was like, okay, so first we actually do lifestyle changes if the patient is in this category. So, like, generally healthy, like, a 30-some-year-old, and they have elevated blood pressure, like if it's above 130 over 80. So we want to do lifestyle changes to begin with. This is a change from before, because before what we used to do is just start them on meds. Now we're like, first, you need to evaluate what you're doing. Is your diet okay? Are you exercising enough? Are you taking those measures first before we throw meds onto you? And I think that's a great thing. Like, really make sure that people first do everything that they can before just taking meds. And then we'll start them only if the blood pressure is still elevated despite those interventions. We would continue the non-pharm. We would continue the lifestyle changes in addition to the medications, but our first step now is just to do the lifestyle changes, which wasn't the case before, just as an FYI. Special populations. So this is for patients who have like underlying diabetes and CKD. So as far as like choice of drug goes, I'll get to, well, you guys already know this because Dr. Cohen went over this with you. We have our ACE inhibitors and ARBs. So you would use either or to slow kidney disease and reduce cardiovascular risk. Those are our preferred whenever a patient has diabetes or CKD. And then same with like just hypertension and CKD. So there's a benefit seen with using an ACE or an ARB in that situation. Okay. So this is the same thing that I just said, but just in table form, and hopefully it's easier to look at. So as you can see, we have our patient group who has high blood pressure and cardiovascular disease risk of less than 7.5%. And then you can see like a 130 to 130 over 80 or higher is what we would look at. If it's still in that range, like persistently high after we're doing lifestyle interventions. And just to clarify this further, lifestyle changes are the same thing as like non-pharmacologic changes. Same thing, okay? And I'll get into like the specifics of what those are, but just so you know, like it's the same thing. And so first line, as mentioned, lifestyle first, and then the meds if the blood pressure persists. And then the preferred drug class, so that's based on comorbidities. So there's a slide that I have with like compelling indications. We'll get to that. But yeah, so this is pretty much just how you can approach each patient group. Questions, comments, concerns. I'd be more than happy to clarify them at this time. Just give you all a second to absorb this, take this in. Yes.
So for the diabetes, I know that we haven't gone into like our endocrine.
Yeah. Yes.
But like does like I know that like one of the complications of diabetes is that you have kidney damage.
Yeah. Yes.
It's like because like the like glomerular pressure increases as hypertension because of the diabetes, and I don't know, but what is the pathophysiology behind it? But
so you'll get more of that in endocrine, but I will say it's considered something called like a microvascular complication. So it refers to like what you're kind of getting at, where the patients can experience something called retinopathy, nephropathy. Retinopathy has to do with the eyes, nephropathy has to do with the kidneys, and then also neuropathy. That has to do with the nerves. It's all intercorrelated with the cardiovascular system. So in a way, like if uncontrolled diabetes is the case, then yes, it would affect, like blood pressure as well, or like the control of hypertension as well. But yeah, more to come in the actual module once you get there. But yeah, that's a good question though. But as far as the treatment approach, does anyone have any questions about how it's done? Oh, I guess one thing I can clarify is this 7.5%. Okay, you will not have to calculate this. This is not something that will not be provided for you. Like say I give you a case, you will be provided this information with like the rest of the details that you need to know, like labs and other history, conditions, all that jazz. Like you will be provided that information. And I'll get into like where this percentage even comes from. But just so you know, it's not like something that you will have to calculate yourself or put into a formula or anything.
And that percent looks like, what is that percent again?
I'll get into it in the next slide, actually. It's like a newer edition. And so, yeah, I'll explain the details of it. But yeah, anything as far as a treatment approach, anything that doesn't make sense to anyone or that you want to clarify? Okay. So this is what it is. It's called the Prevent Risk Estimator. Like basically we have this like calculator to determine the risk of atherosclerotic cardiovascular disease, long term for basically different like cardiovascular complications that can come up. Some examples of this are like myocardial infarction, peripheral artery disease, stroke, things like that. And we'll talk more about this later in the module. It's going to come up again for sure. But basically, as you can see, it estimates the 10-year and 30-year risk of how likely is a patient going to develop that condition or like the group of conditions in that group. And it guides treatment decisions, including hypertension management thresholds, as we see here. Again, you will not have to calculate this. Like I'll tell you, say patient's risk is 10% or 20% or whatever. So the key features, there used to be something called the pooled cohort equations in the previous guideline version. Now this includes both cardiovascular disease and heart failure outcomes, which is really nice. Like it's more inclusive of everything. The population diversity, so it comes across like more than 6 million US adults across multiple racial and ethnic groups, incorporates modifiable risk factors to improve preventive core strategies. So to the question about race from earlier, this calculator, like this risk estimate basically accounts for some of those things. And as you can see, there are the inputs that are here for you for your reference. This is the link, by the way. Like if you're curious to see what it looks like, you can just literally use this link, copy and paste it into Google, and then see what the calculator looks like for you. And then you would just put in, like, as you can see, age, sex, race, and ethnicity, systolic blood pressure, cholesterol, all that stuff. And so that's going to produce a percentage, and it's going to be either, you either can group them under the 7.5% or 7.5% or higher. And then that will just drive your treatment decisions. You will not have to memorize this, as I have highlighted. So again, I will tell you what the percentage is for a patient. You just have to be able to interpret it to decide whether the patient will be in, the first group or the second group, if that makes sense. Like you'll just have to use this table as a reference. Yes.
What does it matter apart from using it for the table? If I'm talking about from the patient's outcome perspective, if it is 10% or 20%?
Well, I mean, it's driving your treatment decision, right?
Yeah, but apart from that, what would there be a difference in patient's outcome if they are not meant for treatment? Is it like if somebody is like 10%, it means the person is going to be maybe like 20%? What are the expectations?
Well, from a proportional standpoint, the higher the percentage, the higher the likelihood of developing atherosclerotic cardiovascular disease. So from that standpoint, they're just considered higher risk. And so you're just going to have to manage them, not only from like, I think, a hypertension standpoint, but you probably have to see like, are there the other chronic diseases that they have, are they optimally managed or not? So that's the way to interpret it or the way to approach it. But as far as treatment goes, the categorizing is here. Any questions? Oh, and then time. Oh my God. How are you guys doing in terms of like energy? Do you need a break? Okay, we'll stop here. So 5 minutes, or wait, let's see. Let's I like to do even time. So it's 2:23. We'll just come back at 2:30. Just keep it clean.
No, that was great, actually.
Yeah, I can buy it.
Not that bad.
Not bad.
It's the best one.
Not bad. I like it.
Very expensive,
I'm getting gains for some reason. I don't know how it's but I'm getting gains. Even my
Your brain, people go.
I mean, I do. I don't know. It's building muscle to move rather fast.
I think 27 years off, that's like 30 pounds with more than like that. I'm thinking, I don't want
Ernesto, ¿está hecho un dorito? ¿Está hecho un dorito? Sí, tienes la espalda ancha, papá.
Un dorito, está buena.
Sí.
I'm not really, but I'm not doing the exercise. I think that's it.
Low carb diet.
Yeah.
Try not to eat at night. Sometimes yesterday when the spread first, I did a lot of like they sell this chips which are totally hummus. I had a lot. It's allergic. Sometimes like not bad because it's so carbohydrate because sometimes I take like medication to sleep when I can't sleep. Makes me really short. Yesterday I couldn't sleep and I didn't sleep. I took the medication. I was like, drowsy immediately. Look how I'm doing. So.
But sometimes, well, yesterday I should have taken my product, but I didn't. And I went to bed. It sucks, but I just sleep it off.
Yeah, you know what? Yeah.
Yeah, I need it.
And I was like low carb, like chicken or chicken breast or sides are more tasty, but they have
I don't mind the fat. I'm not trying to. Yeah, I'm not trying to be lean or something, but I want to be like.
Yeah, you're doing great. You're doing great.
No sé 60 días para que pague los billetes.
Dr. Naim?
Hi, no, you're totally fine.
I saw your email. So, should I get like the stuff with Dr. Park?
I think so. I know there's an approved absence form that comes from the office of either Dean Shimoda or Dr. Park. They have it, or they can provide it. And that way, it's like the paperwork, just ensures that if you're out, it's not a big deal. Like we'll work around it.
Okay. Is
Yeah,
that we already have the presentation and the poster is almost finished, so I have that. So. It is exciting, yeah. But I didn't want to, be responsible and not say something.
No, that's awesome. What is your topic?
I'm doing two research. I'm doing one with Dr. Mohammed, which is separate.
Okay.
But this topic is for Dr. Hall.
Okay.
It's like she gives class remotely.
Yes,
So
yes,
it's
yes.
like remote. I'm doing it with Jesse actually.
Okay,
Yeah,
that's
yeah,
exciting.
yeah, yeah.
Okay.
It's like what's the role of a remote faculty in an in-person program?
Got
And what
it.
is like the advantages, disadvantages, and the perception of the students. Like we didn't get an RB because we haven't surveyed students. It's just like a conversation of what we have and from the data of the evaluations. So we think that like put a perspective on, because maybe you move like Dr. Hall, she's an army wife, so she has to move, and if like there's a vacancy and she has a lot of experience, so we're presenting that.
Got it.
Yeah, that's our
Very interesting. That's a good project.
Thank you.
Yeah, yeah.
Okay. Alright, just wait your turn. Okay, now that one more. Like, we need to write something.
Okay, it's 2:30. We'll just resume, pick back up. I'm gonna probably get to like halfway through the slide deck, so there's not that much left. Maybe I'll get to wrap up early with you all today. Again, depending on how far you want to go, I'll leave it up to you because we have 3 days. So if you want to like stretch it out or you want to be done by tomorrow, let me know. Does anyone have any thoughts already? Like, how do you want to do this?
I say
Is this the only?
What's that?
This is the one.
Slide deck. This is the one slide deck.
Today, Friday, and Monday.
I don't know. I say we skip tomorrow. And we stretch everything on Monday. What y'all think?
Yes, I think that. I agree. No, I disagree.
Why not?
Because y'all have on Monday.
I mean, I love it.
Okay.
We can finish tomorrow.
Okay.
Yeah, and then that way we got 3 days of
And Tuesday we have the.
Yeah. Okay. All right.
Oh, it is almost like
Okay. So yeah. So we'll play it by ear, but I'll keep going. And then if you feel like okay, like I'm gonna say halfway through is like around what was it? What's the math? 39. Slide 39. We're on slide 22 right now. So let's see how we feel by like slide 30, 39-ish. And then if we want to keep going, great. If not, we'll stop there for today. So we'll start with like treatment, non-pharm, the things that we do as far as lifestyle changes go. So all patients, they need to undergo these non-pharmacologic interventions or lifestyle changes unless contraindicated. Which goes without saying. A lot of these are intuitive, like things that you've, worked on counseling and care lab or like just heard of as like the obvious things that you want to ensure patients do. So the weight loss, making sure that they're at a normal BMI, DASH diet, some of you may have heard of that. So that's like basically a well-balanced diet that has like fruits, vegetables, low-fat, dairy, reduced content of saturated and total fats, and then restricting sodium. So that's a big counseling point. That is the most important restriction as far as that goes, ensuring that patients are, like they're trying to restrict it to less than 1,500 milligrams a day or 1.5 grams. Sometimes that's not realistic, so we start at like less than 2 grams, and then it's like, try to get it as low as you can. And then physical activity, the golden number is 150 minutes of exercise a week. So that's usually what we try to counsel on. And then alcohol and smoking cessation, like just trying to limit that as much as possible. So these are, pretty intuitive things that like you probably have heard. But just to review, we do emphasize how important it is for patients who have hypertension. As far as just the general approach goes, so we start off with the first line medication. If the blood pressure goals are not met within the first month of treatment, then we titrate the first line medication to maximum tolerated dose, and then we add a second first line medication from a different class if needed. Or another approach that you can take is do 2 first line medications together, like simultaneously, and then titrate both of them to the maximum tolerated dose.
The guidelines recommend this for like stage 2 hypertension folks, just because their blood pressure is higher. So using 2 different mechanisms is theoretically supposed to like lower blood pressure faster and like more in terms of like efficacy, it's like better. So that's the approach. Now, if the second approach, like using 2, leads to frequent hypotensive episodes, like if the patient's frequently low on blood pressure, with using 2, then obviously you would try to scale back on 1 or try to take it off and then just stick to like the 1. So it just depends from patient to patient. No one way is preferred. Like some clinicians love to do just 1 after the other, and then some like to do 2 at the same time. So it just depends on whatever someone would like to do. And then if the goal cannot be reached within 2 first-line medications, then we add and titrate a third. And then we never want to use ACE inhibitor and ARB together in the same patient. Any thoughts as to why? Like this has come up before, but like basically you guys know the science. Like what's the reason for that?
They work in like the same.
Yes, they're working this along the same pathway, the RAS pathway, right? So it's considered duplicate therapy. And then we'll go over the clinical considerations. There's a lot of overlap with them. Like it's literally the same drug, but like just different variations. It's kind of like fraternal twins, if you will. So they're very, very, very similar, which is why you can't like use them both. If the goal cannot be reached using initial therapy, recommendations or 3 first-line medications aren't enough, then you use a second or third-line agent from other classes. At that point, a patient is considered to have resistant hypertension. There's a slide on that later, but just so you know, the exact term for that is like having resistance or refractory hypertension, where like 3 medications aren't cutting it, so you have to add something else. And then if the patients, they will frequently require several medications to achieve blood pressure goal. Or what I'm trying to say is like, you likely will have patients who will not only, like one agent may not necessarily cut it. Like the hypertensive patients that I see, most of the time they're on multiple. It's great if they're on monotherapy and it's working for them, but usually there is need for more than just 1. Okay, so the 4 preferred drug classes, as we reviewed, we have our ACE inhibitors and ARBs and calcium channel blockers, as well as thiazide diuretics. With the calcium channel blockers, we have 2 types. Dr. Culhane covered both types with y'all? Okay, great. The one that we use for hypertension, though, is the DHP or dihydropyridine calcium channel blockers. Non-dihydropyridine are typically used in patients who have like underlying arrhythmias. So if we're trying to get their heart rate in control and they have hypertension, then that's usually where they come into play. But they're not going to come into play like for now. So the only ones we'll focus on are the DHP ones. And then compelling indications. So this is basically where we use these treatments in the treatment of other disease states due to a beneficial outcome beyond their blood pressure lowering effect. And I'll get into that with y'all. So this is what that refers to. So say a patient doesn't have any compelling indications, then we could go with any of the first-line agents. If they are an African-American patient with no compelling indications, then we prefer to opt for a thiazide or a calcium channel blocker, usually, again, the DHP ones. So the guidelines still have this where like there is thought to be not as much of like a benefit in using an ACE inhibitor or ARB in African-American patients who don't have a compelling indication. Like the blood pressure lowering effect is not up to par with patients of other races. Yes?
Why the difference between line 1 and line 2?
You mean?
There are no compelling indications in both cases.
Yes, but African-American patients specifically, there's a slide, and in the comments, I have detailed out the details as to why African-American patients are still not considered good candidates for ACE and ARB therapy. So I'll get to that whenever that slide comes up. but like there is a reason for why. But the bottom line, in the simplest way possible, I'll just say that ACE inhibitors and ARBs, they just don't do as good of a job as far as blood pressure lowering goes if there are no compelling indications in African American patients. Therefore, we have to rely on these mechanisms, the ones that calcium channel blockers offer and the ones that thiazide diuretics offer. We just don't achieve that same efficacy with those. And there's a comment that gives you all, I'm pretty sure we have the same slide deck. So you'll see the comment and I'll indicate it to you when we get there. Yes?
Compelling indications, that means like, for example, no CKD or no heart failure or no like other comorbidities or like.
Specifically,
okay.
Yeah, so
okay.
this defines it. So like when we have agents that are used in the treatment of other disease states due to beneficial outcomes beyond just lowering their blood pressure. That's what that refers to. Okay. Yeah, so this is, how treatment is approached. And then we have stable ischemic heart disease or previous MI. For them, we would usually opt for an ACE or an ARB, or maybe even a beta blocker. And I'll get to beta blockers eventually. I'm not too pressed about covering beta blockers with you, but just so you know, just in case. There are certain beta blockers that have good blood pressure lowering effect. So we may opt for that in that particular group of patients. Heart failure, we'll get into all the details of heart failure eventually, but as you can see, there are some drug classes here. Like for example, we'll cover aldosterone antagonists, but loop diuretics, for example, that'll come up in great depth when we actually cover heart failure. And then chronic kidney disease, ACE or ARB, as we reviewed earlier. And then secondary stroke prevention, we opt for thiazide, ACE inhibitor, or ARB. Okay, so this is just an overview of like how certain drug classes perform better in certain conditions and in certain types of people.
Dr. Nine, so I'll go to secondary stroke prevention. If I'm doing that for a Black patient who already has hypertension, it's going to be thiazide, never the ACE or the.
No, just we have to have like a Black patient and they don't have compelling indications. When it comes to compelling indications, that's where we see enough of a benefit with that particular condition, even if they are African American. So we can see that benefit with them. That data it indicates that it works for them. But if a patient only has hypertension and they're Black, we use if we use an ACE inhibitor or ARB in that particular patient, their blood pressure lowering is just not going to be up to par as compared to a thiazide or a calcium channel blocker.
And that's based on research.
Correct. So like the way that the data was looked at was Black patients without any other comorbidities and Black patients with certain comorbidities, as we can see here. And so when they have these other comorbidities, aka compelling indications, we can still use these other classes or like use the ACE inhibitor and ARB classes. Okay. And that goes to show that like that particular comorbidity or compelling indication is probably linked to the patient's hypertension. So if we get that condition under control, like say they have heart failure, okay, and so if we use an ACE or an ARB in them, which by the way, ACE ARBs are like one of the most important classes of treatment that we use in heart failure. So by using that, it helps to get their blood pressure under control right away. But again, if we have an African American, no compelling indication beyond that, like they just have hypertension, that's it, then using an ACE or an ARB is just not going to be as efficacious for blood pressure control. Does that make sense to everyone? Okay. So then when it comes to choosing what we do, as far as like what treatment do we go with, so we look at like therapeutic benefit, place in therapy, comorbidities, like as you saw in the previous slide, safety, so looking at like contraindication, side effects, drug interactions, and then administration, so like dosing, availability, pricing, as well as counseling points and clinical pearls. So I'll get into the specifics of each drug class, but They're all generally like well afforded. Like none of them are super restricted or anything like that, thankfully. Just because like they've been around for a long time. All the drug classes, I mean. But like usually we get into it gets tricky with like ACE inhibitors and ARBs are a little picky with like causing a little bit of kidney dysfunction, causing high levels of potassium. If a patient is allergic to the RAS inhibitor class and they are at risk for developing angioedema, things like that. So those are some things to take into account with that particular class. Question?
It's causing kidney dysfunction with these and ARBs. But we know they protect the kidneys. So
Yeah.
in what case do they really cause that dysfunction?
Yeah, so it's usually more acute. When we first, that's a really, really good point. When we start a patient off on a RAS inhibitor, like ACE or ARB, they cause this like sometimes acute increase in serum creatinine. And then usually it's just a matter of taking the patient off of it and then introducing it more like at a lower dose and then slowly titrating up. So it's a very like paradoxical thing because it's like they're supposed to be nephroprotective, but then they can cause that acute issue. We don't try to start it if a patient already has underlying acute kidney injury, meaning if their serum creatinine is fluctuating a lot, if you introduce an ACE or an ARB in that particular time frame, it's going to make things worse. So you wait until the patient is stable as far as their serum creatinine trend goes. But yeah, that's a really, really good point. Does that make sense to everyone? Oh, I don't know if I said this. So the lecture is being recorded. It's going to be posted via or on Canvas via Panopto. So it's all going to be up there for you. Okay, so getting into diuretics, let's see what our slides. So we're on slide 27. Okay, 28. So the first class is thiazides. So these just, as far as like background on which trials proved this class's benefit, it was the ALLHAT trial. I don't ask questions in regards to this. Can someone please? Okay, good. Sorry, I was gonna be distracted the whole time. So as far as the trial stuff goes, I don't ask questions pertaining to that stuff on my exam. I will say, like, I do remember, thinking further down the road, board exams sometimes get into like the landmark trials. So like we do ask questions sometimes with like something that was really, really major as far as changing clinical practice. So for that reason, like I'm just including it here for your reference. But as far as the like exam goes, I'm more so concerned that you recognize like it's a first line class of medications. And then they're just considered to be like, beneficial as far as like, improving life and making sure that the patient doesn't like worsen as far as hypertension goes. And then of the thiazide class, we have chlorthalidone, which is like considered to be preferred per the guidelines. There's hydrochlorothiazide and then there's chlorthalidone, which are considered the more common ones. But hydrochlorothiazide is like more commonly seen, but chlorthalidone is like more potent. So yeah, it just works better. And then some side effects to make note of. So the main thing that I can highlight is thiazide diuretics, they like decrease your electrolytes, as you can see here. The only electrolyte that they increase is calcium, and then also can cause potential increases in glucose levels and uric acid. Uric acid, particularly, like what condition does that complicate? Gout. Yes, absolutely. Yes. So hyperuricemia, thiazide diuretics can make that worse. Good. And then electrolytes, as I mentioned. So calcium is the only electrolyte that goes up instead of down. The rest of these things, so the dehydration, dizziness, hypotension, that's kind of the case for like all antihypertensives, which makes sense, right? Like they lower your blood pressure, so then it could cause those things. And then you can see like the potential sexual dysfunction, photosensitivity, those are some things as well. Safety-wise, like other things, so there's a cross-reactivity that's noted between sulfonamides and non-antibiotic sulfonamides, aka thiazides.
So there's like just the concern, like sometimes when a patient has this allergy documented, we just always just make sure that they're safe to receive it. Sometimes a test dose is given. Sometimes we check to see if they received a dose before and nothing happened, things like that. So just so you're aware, that's kind of the way that that's approached. And then if a previous reaction to sulfa antibiotics was severe, then avoid exposure to thiazides. For drug-drug interactions, more FYI, as you can see, but just so you're aware, there are interactions that exist with thiazide diuretics. Okay, and then they're given usually once a day, available in combination medication products, and they're generic and inexpensive. The dosing, it's the same for both, which is kind of nice, easy to remember. Chlorthalidone and hydrochlorothiazide, it's 12.5 to 25 for both, so easy peasy. And then counseling-wise, so because it's a diuretic, there's concern for frequent urination. So we try to counsel patients on taking it earlier in the day so that they're not having to go to the bathroom throughout the night. May initially increase urination, but should subside after a few weeks. And then increased risk of hypotension, hyponatremia, aka reduction in salt, if very low salt diet. And then other things are, just, chlorthalidone and hydrochlorothiazide, aka HCTZ. Chlorthalidone is longer acting, which is why it's preferred. And then thiazide should be used with caution as renal function declines. So they're not as effective with the lower creatinine clearance. And then, the higher you go with the hydrochlorothiazide dose, the more electrolyte abnormalities can result. Okay, potassium-sparing diuretics, I'm not going to spend a lot of time on them because they're not technically first line. So again, thiazides are first line. Okay, we do resort to them, as you saw with like the compelling indication slide. Those are our go-to. These are not, because they're not that effective. And then just going over them for completion. So the main one that I can think of, there's amiloride, there's acetazolamide. They're used as combination with the thiazide diuretic typically, again, to balance out the potassium levels, because thiazide diuretics deplete the patient of potassium, and then potassium-sparing diuretic ensures that it's normal, enough stores of it in the body. So that's why they're used in combination, but they by themselves are not good at reducing blood pressure. So we don't really see them by themselves. And then, this is more so for your reference because I'm not trying to really test you on them. The most that you should know is that potassium-sparing diuretics, we don't use them as first-line agents. They're add-ons, just for the sake of making sure a patient doesn't have low potassium. Now that's kind of fallen out of favor anyway, because when you think about ACE inhibitors and ARBs, they cause hyperkalemia, as in they cause higher potassium. So say a patient's on an ACE inhibitor or ARB plus a thiazide, the chances of them having normal potassium are there, given, they already have an agent that would probably increase their potassium. So we don't really use them that frequently, but you may see them in practice, which is why I left the slides in here. We'll just keep it moving. Oh, this cuts down our slide. Okay, we're already at 36. Okay, how are we doing in terms of energy? Do we want to keep, when do we want to stop is basically what I'm trying to ask. Because again, we have ample time. So do we want to stop soon? As in, let me, I guess, we'll stop right before RAS inhibitors. How about that? That's not that much left. Okay. Because I kind of just skipped past the potassium sparing diuretics because it's not really relevant like that. Okay, this is another subset of potassium sparing diuretics, but they're called, technically we shouldn't call them diuretics because it's not so much that they work as a diuretic, if that makes sense. Their more function is along the lines of inhibiting aldosterone. And then they're also referred to as the super long word here, mineralocorticoid receptor antagonists. So that's a better way of grouping their class or classifying that class of medications. Examples are spironolactone and eplerenone. They're not used first line for hypertension, so again, this is also not our go-to. But I do want to highlight these because, for one, they'll come up again in heart failure, and then they may be great for adding on when a patient has a resistant hypertension. So like we're doing 3 first-line medications, and we need to add something on as a 4th agent. Usually it's going to be one of these. And they work really well. Like they're excellent blood pressure lowering agents. So that's why I do want to point these out and indicate to you that yes, like these matter. And yeah, so as pointed out, more potent than other potassium-sparing diuretics, and they're part of the standard therapy for heart failure. There are beneficial outcomes beyond blood pressure control. And then, as I mentioned, resistant hypertension. Okay, side effects. So spironolactone has the common side effect, unfortunately, of gynecomastia, which is the enlargement of breasts, which, as you can imagine, that like sucks for men to experience that. So for that reason, if patients experience it, we have the option to switch them to eplerenone. Eplerenone is more expensive though, so that's one trade-off. But yeah, we have to deal with that sometimes. And then potential sexual dysfunction. That also is more of a concern with the use of spironolactone, not so much eplerenone. And then for women, menstrual irregularities can also result as a result of using spironolactone. So spironolactone has more of that like hormonal imbalance effect, as you can gather. So that's why it sometimes can be problematic, but then the option would be to switch to eplerenone in that situation. Both agents can cause electrolyte abnormalities. The key one for both of them is high potassium. So they can especially do this in reduced renal function. And then they can also cause low sodium. So high potassium, low sodium is what can happen. And then as far as contraindications go, the key thing is we look out for significant renal impairment. So if their creatinine clearance is less than 30, potassium greater than 5. Eplerenone, a little bit more specific. More so for your reference, but I would particularly try to remember that these agents, like if you have poor kidneys and high potassium, you may not be a good candidate to safely receive this line of treatment. They interact with ACE inhibitors and ARBs in the sense that they can cause high potassium. Okay, so the concern for hyperkalemia is higher. Does anyone know why we're so concerned around high potassium? Like, what can that do? Arrhythmias, absolutely, yes. So it can lead to life-threatening things for a patient if the potassium is too high. And there's like a whole protocol in place that you sometimes have to like implement to ensure patient's potassium is within range. So we want to avoid that from happening. And then yeah, just eplerenone has like drug-drug interactions with certain meds as well. These are dosed once or twice a day. I typically see just the once a day dosing. Now, you see there's a difference as far as the dosing. I typically see like 25 to 50 for both, if I'm being honest. Sometimes we may even start off at 12.5 milligrams a day, just to be conservative with like our, like if a patient has concurrent use of an ACE inhibitor or ARB, and then we throw on a one of these, then our concern would be like causing hyperkalemia. So we usually start off a little bit lower. 12.5 milligrams a day is usually a safe place to start the patient off on. And then as I mentioned, like eplerenone, we have a generic, but it's more expensive than spironolactone. Yes?
So in this case, when we are having potassium loss, it makes sense to just give potassium supplements instead of having to go to a higher medication that is more expensive.
Could you repeat that just to make sure I understood what you were saying?
The patient is on spironolactone.
Yes.
Because we wanted to be potassium sparing. But because of chematomastia, we decided to go to eplerenone, which is less, we give less side effects.
No, but it still causes hyperkalemia.
Yes, so I'm saying instead of going to dogs, does it make clinical sense to keep the patient with the thiazide diuretic and just add potassium as a supplement?
You can do that if their potassium is low, but if you want to add that blood pressure control and say like they're in this resistant sort of blood pressure category, then we would likely go with one of these. And then that would help to regulate the potassium
Because
level.
with the thiazide already, we're already getting the blood pressure under control. The only problem we're having is potassium. And that's what
Oh,
we're looking
if
at
the only problem is potassium, then yeah, you would supplement them with potassium. I thought you were saying like if their blood pressure is still not controlled.
No, I'm saying we are using thiazide. The reason why we are sparing is because thiazide is losing potassium, and we are switching from one diuretic to another because we want to spare potassium. I'm saying it doesn't make clinical sense to stay with the thiazide and instead of switching,
Yeah.
use potassium as supplements.
Yes, you can do that as long as the blood pressure is at goal. So that's the main like point that you would look at. If the thiazide is doing a good job by itself at controlling blood pressure, then keep it at the thiazide. You don't need to add like another agent, you know. Those weaker potassium sparing diuretics, like that was historically done, but you could either do this option where like we have amiloride plus hydrochlorothiazide or trimethoprim plus hydrochlorothiazide. There's that option, or to do the potassium supplement option. So like it depends on preference. Yep. Any other questions about the approach to managing hypertension so far? Okay. Did I go? Oh, these are counseling points. I was like, wait, I don't think I read these yet. Okay, but you know, so counseling wise, we would not want the patient on potassium because in addition to this class, it's gonna like make the potassium skyrocket. So making sure that they're not like taking additional potassium. Monitoring for hyperkalemia, those are some common side effects that you may see patients have. Increased risk of hypotension or hyponatremia. And then if gynecomastia occurs and switched to eplerenone, which we discussed, can minimize side effects by using lower doses, which is the whole 12.5 milligram dose concept. And then renal dysfunction, we have increased risk of hyperkalemia. So that is that. Yeah, we're at a good stopping point, I think. So we'll pick up on RAS inhibitors tomorrow.